Bismillahirrahmanirrahim. Assalamu alaikum. This is me Nazir Ahmad from Pakistan. Today our topic of discussion is drug clearance by the kidney. If you are new on my YouTube channel, please subscribe to my YouTube channel and press the bell icon button so that you may not miss any upcoming video. Drug clearance by the kidney. Elimination of drugs from the body requires the agents to be sufficiently polar for efficient excretion. Removal of a drug from the body occurs via a number of routes, the most important being through the kidney into the urine. A patient in renal failure may undergo extracorporeal dialysis, which removes small molecules such as drugs. Renal elimination of a drug. Elimination of drugs via the kidney into urine involve the following steps: glomerular filtration, proximal tubular secretion, distal tubular reabsorption, role of drug metabolism. Glomerular filtration. Drugs enter the kidney through renal arteries, which divide to form a glomerular capillary plexus. Free drug that not bound to albumin flows through the capillary slits into Bowman's space as part of the glomerular filtrate. The glomerular filtration rate, 125 ml per minute, is normally about 20% of the renal plasma flow, that is 600 ml per minute. Lipid solubility and pH do not influence the passage of drugs into the glomerular filtrate. However, varying the glomerular filtration rate and plasma binding of the drug may affect this process. Proximal tubular secretion. Drugs that were not transferred into the glomerular filtrate leave the glomeruli through efferent arterioles, which divide to form a capillary plexus surrounding the nephric lumen in the proximal tubule. Secretion primarily occurs in the proximal tubules by two energy requiring active transport carrying requiring systems. One for anions, for example, deprotonated forms of weak acids, and one for cations, for example, protonated forms of weak bases. Each of these transport systems shows low specificity and can transport many compounds. Thus, competition between drugs for these carriers can occur within each transport system. Note: premature infants and neonates have an incompletely developed tubular secretory mechanism and thus may retain certain drugs in the glomerular filtrate. Number 3. Distal tubular reabsorption. As a drug moves toward the distal convoluted tubule, its concentration increases and exceeds that of the perivascular space. The drug, if uncharged, may diffuse out of the nephric lumen back into the systemic circulation, manipulating the pH of the urine to increase the ionized form of the drug in the lumen may be done to minimize the amount of back diffusion and hence increase the clearance of an undesirable drug. As a general rule, weak acids can be eliminated by alkalinization of the urine, whereas elimination of weak bases may be increased by acidification of the urine. This process is called ion trapping. For example, a patient presenting with phenobarbital weak acid overdose can be given bicarbonate, which alkalinizes the urine and keeps the drug ionized. thereby decreasing its reabsorption. If overdose is with a weak base, such as amphetamine, acidification of the urine with ammonium chloride leads to protonation of the drug, that is, it becomes charged, and an enhancement of its renal excretion. Number 4. Role of drug metabolism. Most drugs are lipid soluble and without chemical modification would diffuse out of the kidney's tubular lumen when the drug concentration in the filtrate becomes greater than that in the perivascular space. To minimize this reabsorption, drugs are modified primarily in the liver into more polar substances using two types of reactions. Phase 1 reactions, which involves either the addition of hydroxyl groups or the removal of blocking groups from hydroxyl, carboxyl, or amino groups, and phase 2 reactions that use conjugation with sulfate, glycine, or glucuronic acid to increase drug polarity. The conjugates are ionized and the charged molecules cannot back diffuse out of the kidney lumen. Clearance by other routes. Other routes of drug clearance include via intestines, the bile, the lungs, and milk in nursing mothers, among others. The phases are primarily involved in elimination of unabsorbed orally ingested drugs or drugs that are secreted directly into the intestines or in bile, while in the intestinal tract, most compounds are not reabsorbed and eliminated in the feces. The lungs are primarily involved in the elimination of anesthetic gases, for example, halothane and isoflurane. Elimination of drugs in breast milk is clinically relevant as a potential source of undesirable side effects to the infant. A suckling baby will be exposed to some extent to medications and or its metabolites being taken by the mother. Excretion of most drugs into sweat, saliva, tears, hair, and skin occurs only to a small extent. However, deposition of drugs in hair and skin has been used as a forensic tool in many clinical cases. Total body clearance, the culmination of all clearance methods and drugs half-life or important measures of drug clearance calculated to prevent drug toxicity. Our next presentation will be design and optimization of dosage regimen. Thank you for watching this presentation. If you have any question, please write in the comment section below.